الآن نأخذ موضوع الهايبركاليميا. Plasma potassium concentration over 6.5 millimole per liter requires urgent treatment. IV calcium gluconate has a rapid but short-lived effect in countering the neuromuscular effect of hyperkalemia. The treatment with the glucose and insulin causes potassium to pass into the intracellular fluid. وهناك بالنسبة للأسباب فهناك altered internal distribution of potassium وأكو altered external balance اللي قد يكون increase intake of potassium أو decrease excretion of potassium. نجي على أول واحد اللي هو altered internal distribution of potassium. أكو حالات مثلا حالة الأسيدوسيس. The effects of acidosis on internal potassium balance are complicated. As a general rule, acidotic states are often accompanied by hyperkalemia, as potassium moves from the intracellular fluid into the extracellular fluid. يعني كقاعدة عامة, acidotic states are often accompanied غالبا ما تكون مصاحبة by hyperkalemia as لأنه البوتاسيوم moves from the intracellular fluid into the extracellular fluid. بالرغم, although this is the case for acute respiratory acidosis and for both acute and chronic metabolic acidosis, it is more unusual to find hyperkalemia in chronic respiratory acidosis. إذا بالرغم من ما أنه هذه الحالة هي اللي تصير في الأكيوت respiratory acidosis وفي كلتا الأكيوت and chronic metabolic acidosis, it is more unusual to find hyperkalemia في حالة chronic respiratory acidosis. It is important to note that a high plasma potassium concentration may be accompanied by a reduced total body potassium as a result of excessive urinary potassium losses in both chronic respiratory acidosis and metabolic acidosis. هذا بالنسبة لموضوع الأسيدوسيس. أكو حالة الأخرى اللي هي hypertonic states. بهذه الحالات, in these, البوتاسيوم moves out of cells, يتحرك إلى خارج الخلايا, possibly because of the increased intracellular potassium concentration caused by the reduction in the intracellular fluid volume. وهناك حالة uncontrolled diabetes mellitus. The lack of insulin prevents potassium from entering cells. This results in hyperkalemia despite the potassium loss caused by the osmotic diuresis. وأيضا هناك حالات cellular necrosis. النكروسيس يعني اللي تصير the death of cells, يعني الخلايا اللي تموت. This may lead to an excessive release of potassium, لأنه البوتاسيوم هو أكثر شيء موجود داخل الخلايا, فمن تموت الخلايا راح يطلع البوتاسيوم, lead to excessive release of potassium and may result in hyperkalemia. Extensive cell damage may be a feature of rhabdomyolysis. في هذه الحالة مثال عليها الكراش injury أو الهيموليسيس, البيرنز or tumor necrosis. Example مثال على هذا tumor necrosis in treatment of leukemias. The other cause مثلا digoxin poisoning causes hyperkalemia by inhibiting the sodium potassium ATPase pump. Therapeutic doses do not have this effect. إذن هذني أسباب altered internal distribution of potassium اللي تسبب الهايبركاليميا. بالنسبة للaltered external balance increased intake of potassium. فالincreased potassium intake only rarely causes accumulation of potassium in the body, since the normal kidney can excrete a large potassium load. However, if there is renal impairment, potassium may accumulate if salt substitutes are administered, or excessive amount of some fruit and drinks are drunk, or if excessive potassium replacement therapy accompanies diuretic administration. أما بالنسبة للdecreased excretion of potassium, altered external balance اللي هو بسبب decreased excretion of potassium، فهناك intrinsic renal disease، وهذا this is an important cause of hyperkalemia. Intrinsic renal disease. It may occur in acute renal failure and in the later stages of a chronic renal failure. In patients with renal disease that largely affects the renal medulla, hyperkalemia may occur earlier. This may be because increased potassium secretion from the collecting duct, an important adaptive response in the damaged kidney, is lost earlier in patients with medullary disease. إذن هذا الintrinsic renal disease هو an important cause of hyperkalemia. بعد the other causes mineralocorticoid deficiency. This may occur in Addison's disease and in secondary adrenocortical hypofunction. In both, potassium retention may occur. This is not an invariable feature, presumably because other mechanisms can facilitate potassium excretion. Selective hypoaldosteronism accompanied by normal glucocorticoid production may occur in patients with diabetes mellitus, in whom juxtaglomerular sclerosis probably interferes with renin production. While ACE inhibitors by reducing angiotensin II and therefore aldosterone levels may lead to increased plasma potassium concentration, but severe problems are only likely to occur in the presence of renal failure. والسبب الآخر هو patient treated with potassium sparing diuretics. أكو نوع من أنواع الدايوريتكس احنا potassium sparing diuretics، مثال عليها هنا السبيرونولاكتون والأميلورايد may fail to respond to aldosterone. If the potassium intake is high in these patients, or if they have renal insufficiency or selective hypoaldosteronism, this can lead to dangerous hyperkalemia. إذن هذني الأسباب اللي تؤدي إلى decreased excretion of potassium من ضمن altered external balance. فهذني أسباب الهايبركاليميا. قلنا altered internal distribution of potassium، وقلنا أكو altered external balance اللي قد يكون increased intake of potassium or altered external balance بسبب decreased excretion of potassium. وهناك other causes of hyperkalemia منها artifact. هنا this is the most common cause of hyperkalemia when red cells or occasionally white cells or platelets are left in contact with the plasma or serum for too long. Potassium leaks from the cells. In any blood specimen that does not have its plasma or serum separated from the cells within about 3 hours, the potassium concentration is likely to be seriously high. وأيضا ال blood specimens اللي collected into potassium EDTA اللي هو an anticoagulant widely used for hematological specimens have greatly increased plasma potassium concentration. Sometimes doctors decant part of the blood specimen initially collected by mistake into potassium EDTA into another container and send this for biochemical analysis. A clue to the source of this artifact, which may increase plasma potassium concentration to lethal levels, example, more than 8 millimole per liter, is an accompanying very low plasma calcium concentration due to chelating of calcium with EDTA. إذن هنا بعض الارتفاكت اللي تصير اللي تؤدي إلى الهايبركاليميا. فمثلا إذا البلد سبيسيمن منفصل، يعني البلازما أو السيرم منفصل عن السيلز خلال 3 ساعات تقريبا 3 ساعات، فالبوتاسيوم تركيز البوتاسيوم is likely to be seriously high. يعني إذا انتركت ال RBCs في بعض الأحيان ال white BCs والبليتلتس انتركت in contact، يعني بالتماس مع البلازما أو السيرم for too long لمدة طويلة، فالبوتاسيوم leaks from the cells. هاي حالة. والحالة الأخرى أنه إذا ال blood specimens collected in potassium EDTA، إذا العينات مالت الدم انجمعت في التيوب مالت البوتاسيوم EDTA اللي هو an anticoagulant يستعمل بشكل واسع للهيماتولوجيكال specimens، و have a greatly increased plasma potassium concentration. فهنا هذا يزيد greatly increased plasma potassium concentrations. في بعض الأحيان doctors decant يصب جزء من البلاد specimen من عينات البلاد اللي initially collected by mistake into potassium EDTA اللي بالبداية انجمعا في تيوب يحتوي على البوتاسيوم EDTA by mistake، يعني بالخطأ، وبعدين يحولها يصبها into another container، وبعدين يدزه this for biochemical analysis. فهذا أيضا هم واحدة من الأخطاء. فالclue to the source of this artifact إنه which may increase the plasma concentration to lethal levels. مثلا يعبر أكثر من 8 مليمول per liter، ويكون مصاحب وياه شنو very low plasma calcium concentration. ليش؟ لأنه due to chelation of الكالسيوم with EDTA. إذن ذني الأسباب اللي ممكن نسوي artifact. أكو موضوع السيدو هايبركاليميا. هذا السيدو هايبركاليميا can occur in acute and chronic myeloproliferative disorders, chronic lymphocytic leukemia, and severe thrombocytosis. As a result of cell lysis during venipuncture, or if there is any delay in the separation of plasma following specimen collection, since there are large numbers of abnormally fragile white cells present. Then the other causes of hyperkalemia. الآن خلينا نشوف الجدول اللي يتكلم عن الهايبركاليميا causes of hyperkalemia. هذا الجدول table 2 8 causes of hyperkalemia. فهذا الجدول هناك causes والcategories والexamples والأمثلة. فبالنسبة للcauses أكو artifact example عليها trauma during blood collection, delay in separating plasma, serum, freezing blood. السبب الآخر قد يكون redistribution of potassium between extracellular fluid and intracellular fluid، والأمثلة عليه acidosis، hypertonicity، tissue and tumor necrosis، example burns, leukemia، hemolytic disorders، hyperkalemic familial periodic paralysis، والinsulin deficiency. السبب الآخر abnormal external balance، وهنا increased intake، في هذه الحالة مثلا excessive oral intake of potassium، هذا rare by itself نادر، وأكو decreased renal output، هنا ملاحظة with or without inappropriate intake. هذا decreased renal output يشمل renal causes أو adrenal causes. بالنسبة لrenal causes فقد يكون renal failure، oliguric acute and chronic، أو inappropriate oral intake in chronic failure. الإكزامبل الآخر قد يكون failure of renal tubular response due to systemic lupus erythematosus، potassium sparing diuretics، أو chronic interstitial nephritis. وبالنسبة للأدرينال causes فهي أمثلة عليه Acidosis disease و selective hypoaldosteronism. إذن ال causes of hyperkalemia كما في هذا الجدول. وهناك other investigations in disordered potassium metabolism. مثلا urine potassium measurements may be of help in determining the source of potassium depletion in patients with unexplained hypokalemia, but are otherwise of little value. A 24-hour urine collection should be made. If the patient is sodium depleted, this will induce aldosterone secretion, while making the result difficult or impossible to interpret. ولهذا so urine sodium concentration should also be checked to ensure this is adequate. While in plasma total CO2 concentration may prove helpful in the investigation of disorders of potassium balance. Since بسبب metabolic acidosis and metabolic alkalosis are commonly associated with abnormalities of potassium homeostasis. It is rarely necessary to assess acid-base status fully when investigating disturbances of potassium metabolism. Plasma total CO2 concentration often suffices. Other investigations may be indicated by the history of the patient's illness and the findings on a clinical examination. مثلا hypomagnesemia may be associated with hypokalemia. ولهذا المغنيسيوم concentration should be checked in cases of a prolonged or unexplained hypokalemia. وبقى الموضوع الأخير بهذا الفصل يخص fluid and electrolyte balance in surgical patients، يعني في المرضى اللي يخضعون للجراحة surgical patients. Accidental and operative trauma produce several metabolic effects. These include يعني هاي metabolic effects مثلا يصير breakdown of a protein, release of potassium from cells, and a consequent potassium deficit due to urinary loss, temporary retention of water, use of glycogen reserves, gluconeogenesis, mobilization of fat reserves, and a tendency to ketosis that sometimes progress to a metabolic acidosis. وأيضا هناك هرمونات hormonal responses include increased secretion of adrenal corticosteroids with temporary abolition of negative feedback control and increased secretion of aldosterone and vasopressin. And then high accidental and operative trauma produce several metabolic effects اللي تكلمنا عليهم. These metabolic responses to trauma are physiological and appropriate. They are the reason why post-operative states are such frequent causes of temporary disturbances in electrolyte metabolism. إذن هذه الميتابوليك responses، هذه الاستجابات الميتابوليك للتروما are physiological and appropriate. They are the reason why post-operative states are such frequent causes of temporary disturbances in electrolyte metabolism. Most patients after major surgery have a temporarily impaired ability to excrete water load or a sodium load. They also have a plasma urea concentration that is often raised due to tissue catabolism. إذن أغلب المرضى بعد الميجر up surgery عمليات الكبرى have a temporarily impaired ability to excrete a water load or a sodium load. Where they also have a plasma urea concentration that is often raised due to tissue catabolism. Injudicious fluid therapy, especially in the first 48 hours after operation, may correct the chemical abnormalities, for example, by lowering the plasma urea concentration, but only by causing retention of fluid and possibility of acute water intoxication. Patients who present for emergency surgery, with disturbances of water and electrolyte metabolism already developed. يعني المرضى اللي present for emergency surgery لعمليات طارئة وهم عندهم أصلا disturbances بالwater and electrolyte metabolism، فلازم should have the severity of disturbances assessed and corrective measurements instituted pre-operatively. This usually involves clinical assessment and the measurement of plasma urea, creatinine, sodium concentration, and potassium concentration as an emergency. Ideally, fluid and electrolyte disturbances should be corrected before surgery. Patients admitted for major elective surgery who may be liable to develop disturbances of water and electrolyte balance post-operatively require pre-operative determination of baseline values for plasma urea and creatinine, sodium concentration and potassium concentration. Post-operatively, any tendency for patients to develop disturbances of water and electrolyte balance can be minimized by regular clinical assessment. إذن post-operatively بعد العملية any tendency for patients المرضى to develop disturbances of water and electrolyte balance can be minimized وكان يقلل by regular clinical assessment. In addition, plasma electrolytes, fluid balance charts and measurements of 24-hour urinary loss of sodium and potassium or losses from a fistula can provide information of value in calculating the approximate volume and composition of fluid needed to replace continuing losses. إذن هذا موضوع الفلويد and electrolyte balance in surgical patients اللي هو آخر موضوع في هذا الchapter.